What did you do to your foot?
Yeah, what happened?
There was some of your Kaposi sarcoma. Kaposi sarcoma.
Kaposi sarcoma?
Yes.
Good heavens. What does that mean? He's got in the United Kingdom, he has a very, very rare tumour. We rarely see in the UK. For a child of this age to even know what a Kaposi sarcoma is, yet to mention have one, it's taken my breath away, that. And have you had an operation? Have you had surgery?
No pressure. There's no money.
This one painful?
Yes.
This one okay?
Yes.
How old are you?
Repeat.
How old? How many years?
How old are you? 16 years old.
You can't be 16, surely.
Yes.
Well, I'm sorry to hear about your foot. That sounds like it's going to be a bit of a problem for you.
Yes.
Are you going to be able to go to a doctor near where you live to have the dressings?
Yes.
Yes?
Yes.
Do you live a long way from here? Many kilometers from Moshi?
Rombo. I come from Rombo.
Rombo.
Yes.
And you go in a car or a van? Or do you walk?
In car?
You go in a car?
Yes.
Okay.
The father is dead. The father is dead.
Your father's dead?
Yeah.
Oh, heavens.
2002.
He died in 2002?
Yes.
So who looks after you? Who do you live with?
Is HIV.
He died of HIV?
Yes.
Oh dear. I'm sorry to hear that.
So,
What about your mum?
mom is Yupo.
She's where?
She's back to home.
Back home.
Yes.
Do you have brothers and sisters then?
No brother, no sister. Me in
Me and your mum.
Firstborn.
Firstborn?
Yeah.
Gosh, you've got a lot on your plate, haven't you? There's a lot to deal with.
Repeat.
You have a lot to deal with. The fact that your dad sadly died, and it's just you and your mum, and now you've got this tumour on your foot. Mm.
Yes.
Mm. So the tragedy is this little lad's more than likely got HIV and AIDS, and that's why he's got this very unusual tumour. So it's devastating, really devastating.
Ndugu wasikilizaji, leo mimi Daktari Kondo Chilonga kutoka idara ya upasuaji KCMC. Napenda kutoa tangazo na wito kwa wananchi walioko katika manispaa ya Moshi na maeneo mengine ambayo yanazunguka Moshi.
When I first came, I was quite anxious about coming. I didn't know what to expect particularly. I didn't know would what I had to offer be useful or not. So that moment when the doors of the plane open, you get the smell and the sound and the light and everything that just comes in on you. The African sensations, they just assault you. It is different, obviously, you know. They kept looking at the physical surroundings, the state of the houses, the state of the roads, the state of the hospital and stuff. But by the time I came back for the third visit, I didn't look at them at all. In fact, I didn't see them anymore. So what became important more was the people in the situation, the people who were there, and what they were doing. And that's all that matters in the end anyway.
I think people who do international work have got to be prepared for the unexpected. They've got to think outside the box. You're definitely outside your comfort zone, and you have to be able to cope with the unexpected.
The first time that we went out, we went wondering whether we could do anything at all over there. In other words, could we bring our brand of surgery, which is laparoscopic surgery, to KCMC? But actually, when I got there and I saw what the problems were in the hospital in particular, for example, overcrowding, lack of beds, infection rates, it became apparent that actually laparoscopic surgery, with the small incisions, quick recovery, fast turnover, would answer quite a lot of their problems, really. We've now been coming for over 11 years, I think it is. Over that time, you know, we've seen massive changes every year, really.
You've broken two of my ribs. You haven't got anywhere near the support packages that you would have around you within healthcare services anywhere in Europe. And if you are unable to deal with having difficult decisions to be made all the time, then this isn't the sort of work that you should perhaps think about doing.
It seems that the project, or the mission, call it what you like, seems to attract the type of person who wants to come and do the work, who can put up with a bit of arduousness, if that's a correct word, a bit of difficulty here on occasions, and things not running as elegantly as otherwise what wanted to be.
Dr. Leo is very nice to us. He really gives a very big knowledge to us, especially doctors and nurses at KCMC. Also introduced a very new knowledge about laparoscopic, which is very nice to our patients and our doctors. So really, I acknowledge him for what he's doing to us.
Yeah, so I'm doing my bit and you're doing your bit.
Yeah, also he's my best friend.
And so over the last decade or so, we've been coming to work together as part of the multidisciplinary team, trying to do the best for people who are very deserving of intensive here and now kind of work, helping them out of the quagmire and seeing what we can do also in that process of influencing those professional people who are qualifying here to use their skills to greater effect for people in distress.
It was designed as a state-of-the-art, cutting-edge hospital to a German design in early 1970s. But over time, unfortunately, it's had its ups and downs. When you build a hospital, you can't build a hospital for the whole population, so you build it for what you think is an area that you're going to provide for. But of course, in your great master plan, you'd have several of these hospitals, and they were never ever built. So this has become the main regional hospital, one of the 4 regional hospitals in Tanzania. It's somewhere between 10 and 13 million people that it actually caters for. So Northumbria, we would have about 20 surgeons who would deal with 500,000 population, whereas here they've got 2 and a bit surgeons who deal with 20 million. So each surgeon here deals with about 5 million. So that's a hell of a lot more than I did.
This is Pascalina. She came in last year with a contracture to her arm from, I think it was a scald injury. And Jeremy operated on her, and it's much improved, but she still can't get full extension of her arm. This sort of thing in the UK would be complicated enough, but here, without the sort of aftercare and the physio and the follow-up, it's sort of hardly surprising that she's still got some issues and problems. But she's a very good girl, aren't you? She's very cheeky, really. This is Jackson. I think Jackson's just about a 6-year-old maybe. His arm's contracted and his fingers are fixed and they're splayed. And we're hoping that Jeremy can have a little look and maybe do some surgery to try to correct this.
So tell us about the first one then.
Right. This is Jeremy's 3rd visit, I think. He's a burns specialist. He's a plastic surgeon who specialises in burns and reconstructive surgery. So he deals with acute burns and he deals with the effects of burns, so releasing contractures and that sort of stuff.
I mean, looking at him, he's clearly had a full thickness burn pretty much to his whole arm, which hasn't obviously been treated. So he would be one to under general anaesthetic, see if we can get it into a better position, and then he'll be predominantly split thickness skin grafting over all that lot. And we won't necessarily get him into a hugely better position, but his priority is just to get that wound closed. But I think he's got a lot to gain from having surgery. Otherwise, that arm will get worse and worse and worse and worse and worse. Will probably never really heal. So I think we should try and do him.
He's a great guy. He's a typical surgeon. He's cool, calm. Knows what he's doing. No messing. He's just what they need here.
It's truth.
This little boy's on surgical ward. Apparently fell onto a cook fire. I think he's maybe about 20%, possibly slightly more. It's his chest, left upper arm, abdomen, both thighs, and his left lower leg.
I mean, the things to say with him is, A, he's lucky to be alive, because I think most children of his age sustaining that sort of burn here would have died by now. And if he's left like that, he will almost certainly die. I think that is a shocker. There are people here with horrific injuries that are really putting their lives at risk. So there are children, there are adults that have got massive injuries that really in any other environment would have had an operation much sooner. This is a hugely challenging case in terms of us trying to do something for that, which as you can tell, I feel passionately that we should try and help this young lad. Yeah. But that will require a lot of effort from everyone's part, because A, that will bleed an awful lot, that wound, and then we're going to make his injury twice that size if we harvest a skin graft. But it's his only chance, really. As I said, he's lucky to be alive. A lot of the children here with an injury that big won't have even made it this far. So
we've been very lucky, because Dr. Kondo has really been very much a part. He's completely a part of this project.
It's good to see you.
Yeah, it's good to see you too.
Yeah.
Beautiful weather, of course.
Yeah, it is.
And he's been the one constant in the whole project all the way through over the last 10 or 11 years. So we've built up a personal relationship as well.
Can we interrupt? Hello.
And I think that's been absolutely fantastic for me. I think that's been amazing.
Liam has devoted more than 10 years of his leisure time, his holiday time, to come to Tanzania to improve surgical outcomes for Tanzanians. The introduction of laparoscopic surgery to KCMC and to Tanzania has been a massive, massive improvement to healthcare services.
If you look at it in stages, when we went out for the first couple of years, I met with Dr. Kondo and we operated together. Then the next couple of years, he operated with me, assisting and observing really. And then we got to the telementoring phase.
Liam, you're in picture.
Thank God for that, Keith.
Which meant that I could stay, he could operate, and I could obviously communicate with him two ways. And he would operate, I would just give him backup over the audiovisual link.
It was very difficult at the beginning, but gradually we started to gain the experience, and eventually we are somehow independent and confident to do on our own.
We spend a lot of time on this, We spend a lot of time making it work. When we connected this to the internet originally, Moshi Town had 2 megabytes of bandwidth available, that was it. And so we had to get on to the company that supplied the bandwidth, and they said that they would give us that bandwidth when we were operating, which, as you know, isn't exactly that much, but it was enough for us to do what we wanted to do.
we've just found out there's 2 people who've been brought over the border from Kenya with 40 and 50% burns respectively, which are, by definition, massive injuries, very much life-threatening injuries in any country, but especially here in Tanzania. One of the patients is pregnant, so there'll be huge challenges in terms of dealing with these patients. When did they get the burn? Was it yesterday they got burnt, or a few days before?
No, it's yesterday over there, night.
Right.
She arrived, I think, 10 hours.
And so she was involved, it was an open fire, it looks like there was an explosive component to it.
Petroleum.
Were they pouring petrol on to try and get the fire going?
Yes.
Shall we have seeing as we're here, can we have a little look at the burns and see if there's anything we need to do urgently if she's got such large injuries?
The latest ultrasound showed no fetal heart rate, no fetal movement. And we're just wondering what your management for this patient might be.
So my management for this patient would be, ideally, she needs escharotomies of both her lower limbs. At the moment, as far as I can see, she's getting very little, if any, circulation down into her feet. So the operation involves just releasing cuts down the sides of the limb to allow the tissues to expand. If you don't do that, then all those muscles, all the structures inside the legs die. And so she ends up with gangrenous, legs, which will make her very, very unwell, and she'll die pretty quick from bilateral gangrenous legs. So that's why there's a huge, rush to get on and do these things.
I didn't expect to see this on day one, and to see this right from the beginning, it's amazing in a way, but at the same time it's sad because these people may lose their life because of it. So I hope they'll survive, and if we get to theatre today and do the right thing, they've got a better chance.
She's high risk. She's very high risk for not making this.
Okay. So we can arrange for tomorrow for sclerotomy or?
I mean, if you arrange for tomorrow escharotomy, she may not be well enough for that, but it may be better than nothing. The same applies for the young man as well. He needs bilateral lower limb escharotomies because he, as far as I can see, has got ischemic legs, which will make him very unwell pretty soon. So they're both critically unwell and in need of, a lot of intensive care and a lot of intervention. I don't know if they're set up to do much surgery on a Sunday. If someone gets wheeled into the emergency department with no blood pressure, bleeding from the tummy, they'll be rushed in and have an emergency laparotomy, and they'll sort of, in that situation, if someone is literally dying in front of them, they will do an operation. The problem with that is that lady is dying in front of us, but it's not quite so apparent to people who are less trained in these things, and the thought processes will be, well, that can wait till tomorrow. And my experience is that will be too late.
So, it's soon to command
For sclerotomy?
for sclerotomy.
Tomorrow?
No, it's for today.
Today?
Yeah.
Are you going to arrange the theatre?
Yeah.
Because they don't know.
So there's no staff here now, or they just don't do things like this?
They are out. Just like I will call the resident on call.
But that would be my, all I can do is give you my advice in terms of what I think is best practice. And best practice would not be to do it tomorrow, but to do it today.
Okay.
So I'll hang around.
Do you see this little wire here?
Yeah.
That wire tells the whole story. When I came here first, there was a lovely clock, and it said 10 to 2. Right, so it was right 2 times a day. Okay.
Right.
And then over the years, clocks just kind of went like that, started dropping. Every year I'd come in that door full of hope, and the clock would be down. So last year when I came, the clock was missing, and there was little innards just stuck onto the end of the wire. And this year, even that's gone.
Oh dear, dear. What is happening is we're just waiting for the anaesthetist to give us the okay to take these patients around to theatre. I've discussed with the surgeon on call that I think these patients need an operation tonight. That would be my advice, and hopefully they will agree. Is Dr. Julius around? You're going for the patient now, are you? All right. See, I'm so gullible. Until I'm stood there with a knife in my hand with an anaesthetised patient, I will assume that it may not happen.